Dr. Kengasong was Deputy Principal Director of the Center for Global Health at the US CDC and Associate Laboratory Science and Chief of the International Laboratory Branch at the Division of Global HIV, AIDS, and TB. He has a lot of experience in disease control, and we are very honored to have Dr. Kengasong join us in this World Health Summit Regional Meeting for Africa. So our attendees, please join me in welcoming Dr. John Kengasong to make his presentation this morning. Thank you.
Thank you so much. Can you hear me?
Yes, we can hear you, Doctor.
And can you see my screen?
Yes, we can see the screen, sir.
No, wonderful. Greetings from Addis Ababa. And it's a pleasure to join the World Health Summit Regional meeting holding in principle in Uganda, even though we are all over the place. And Thomas, good to see you again. In the next couple of minutes, within my time allotted, I would address three things. I was asked by the speakers to comment on the puzzle of COVID-19 in Africa. And then I would also segue and discuss the current situation today, and then review for you and conclude with some thoughts on the response of this pandemic from within the continent. So let me start then with the puzzle. In last year, actually, or early this year, in January, indeed, we published a perspective in science where we talked about the puzzle of COVID-19 pandemic in Africa, but requested that we needed or more data to understand the determinants of COVID-19 pandemic across the continent. And I think that paper has been well received. When we use the word the puzzle of COVID-19 in Africa, this is what we are referring to. The graph on the top partner represents the cases per day at that time up to January. And then the bottom panel, the graph in red, represents the death rates over this period of the pandemic. And you can see that if you compare Africa with the rest of the world, the cases were relatively accounted for 3 to 4% of global cases. And this is a continent that has weak health systems. And initially, we were all extremely concerned that the pandemic was going to hit the continent very, very severely. You can also see on this curve that the cases, the number of cases, the 7 days moving average, and the death rates, also the 7 days moving average for that actually correlated very, very nicely. So the several hypotheses we have been generated to understand this the puzzle in Africa. First of all is the limited testing, which is required to detect and isolate people. And this is basic public health practice. The decisiveness and timeliness of the leadership of the continent. Very early on, you recall, the continent was able to mobilize all ministers of health. The head of states took control. President Ramaphosa, the chair of the African Union at that time, really took full control of the situation, and the Africa CDC supported that. The third hypothesis we have been putting out there to elaborate or illustrate the paradox is the young population. We all know that the median age of the continent is around 19.9 years. Less than 60% of the population is below 25 years. And then also climatic change was thrown out there as possible hypothesis to explain the pandemic. However, and this is where the puzzles begin, when you conduct serologic surveys, where you ask the basic question as to how many people have been exposed to the virus or are currently infected with the virus using serologic tests, which is a marker that demonstrates that when somebody has been infected, they develop antibodies and you can pick up that antibodies. And if you look at Kenya at that time, that is January, the seroprevalence, that is people that have been exposed to the virus or are currently infected, was 5.6%. That is about 3 million Kenyans were estimated to have been infected at that time in January. But at the same time, if you look at the cases reported, that is based on the molecular testing by polymerase chain reaction, PCR, Kenya was reporting 20,000 cases of COVID-19. So that is a big difference there between 3 million people that were exposed. So it would seem that one of the hypotheses there was valid, that people were infected, but because of the young population, the young age of the population, they were not falling sick. We have since at Africa CDC validated that data across several countries, including in Sierra Leone, Uganda, Zambia, and Zimbabwe, where the left-hand column, which is the overall prevalence, shows you the sero survey across the continent. And we found that in Sierra Leone, 2.8% of the population had been infected. In Uganda, about 20%, Zambia, 13%, Zimbabwe, about 3.1%. This is data that is based on household survey using very systematic, rigorous approaches. If you look at the right-hand side of the graph, it shows you the seroprevalence by gender, and where it is almost equivalent, whether you're dealing with Sierra Leone or Uganda. However, in Zambia, you see that less women, 10.8% of the females had been infected compared to 15% of the male. And Zimbabwe had very similar rates. So the conclusion of this is that many more people have been exposed to the virus in Africa. You recall last year, our testing situation when this pandemic just started, between February and up to May last year, the testing situation on the continent was extremely dire, to the extent that I actually recall writing a paper in Nature calling the world to let Africa into the market of COVID-19 diagnostics. But as of today, because we launched a partnership to accelerate COVID testing in abbreviation pact, 50 million people have been tested with a case per case ratio of 9% and a positivity rate of 10.8%. So our testing has improved, but it's not almost there where we would need to be. So again, we might be missing cases out there on the continent. Now, what is the current situation of COVID in Africa? As we speak today, 5.2 million people have been infected, with a recovery rate of 90% and a case fatality rate of 1.3%. A case fatality rate of 2.7%, I beg your pardon, with a total of 137,000 deaths. If you look at the curve in the middle here, it shows you the 7 days moving average, and the vertical axis represents the daily COVID cases. The horizontal axis is the time, and the different colors you see underneath the red line, which is the 7 days moving average, are the different regions, the 5 regions of the continent. Clearly, you see that we are going through the 3 peaks. The first peak, or what we call the first wave, was around June and August last year. The second wave, which was much higher than this first wave, occurred around January, February, just after the holiday season. And we are now looking at, we are now deep into the 3rd wave, as I'll show in the subsequent slides. If you just pay attention to the rectangle I've included at the very tail end of the graph, and we zoom in on that, you see that in the last 6 weeks, between mid-May and mid-June, the number of cases have actually increased dramatically in the last 6 weeks. And that shows you, again, how aggressive and fast-moving the 3rd wave is. If you summarize the continent, you realize that 53 countries, member states, have experienced the 2nd wave, and 39 or 74% of those countries have observed a very severe 2nd wave. 19 countries, or 35% of our member states, are currently experiencing the 3rd wave, and they are indicated in the dark red colors. And of those, 53% have experienced a very severe wave. And one country, Tunisia, is actually going through a 4th wave. Let me just walk you through the different regions there. If you look at the southern, northern, eastern region, and over the last 4 weeks, you see remarkable trends where numbers are increasing very, very significantly. So let me just spend a few seconds on this graph. And if you see where my cursor is here, that shows you the mid-May period. And we are taking a 4 weeks period of time and comparing the rates of infections at this point and comparing it in terms of percentage changes at this point. If you look at that clearly, and you do your maths, you see that Southern Africa, the cases have increased in Southern Africa by plus 353%. And the peak here represents the peak of the second wave. In Northern Africa, the cases have increased by 18%. And in Eastern Africa, the cases have increased by 50%. Central and Western Africa continue to see a decrease over the last 4 weeks in this window period, which is good news. But if you now zoom in into different countries, so you kind of leave the regions and you go deep into the countries there, you look at South Africa, just over the last 4 weeks, the numbers have increased by over 280%, Namibia by over 400%, Zambia by over 2,000%. You can see a very steep increase here in Zambia, and in Uganda by over 440%, just over the last couple of weeks. Before I leave this slide, it is important to draw your attention to the fact that if you look at the peak of the waves, in Namibia, for example, this is the peak of the second wave, and you see where the third wave, the peak is of the third wave. Similarly, in Zambia and in Uganda, you see clearly that the third wave, the peak of the third wave is significantly way higher than the peak of where we were with the second wave. And look at these other countries, DRC, Sierra Leone, and Liberia, very clearly these same trends there. Very high peaks of the third wave, irrespective of the countries, and especially in Liberia, where they have gone up dramatically. I mean, you can see here where they've gone up almost about 1,000%. Now, so why are we seeing this a dramatic increase in cases? Because there have been across the board relaxation of public health and social measures, and we begin to see public gatherings, reopening of most public places and rallies, and especially political rallies. The population is getting into what we call public pandemic fatigue, low vaccination coverage across the continent. Only about 1.1% of our population have been vaccinated with the full doses, that is 2 doses across the continent. The impact of the new variant, and also the weather, the climatic change in Southern Africa, where most countries are now moving into the winter period, which means there's more indoor activities than outdoor activities. Now, let me expand on the variant situation on the continent. We now know that there are about 4 variants of concern, the Alpha, the Beta, the Delta variants, all of them, those viruses were first reported in the UK, in South Africa, Brazil, and India. And they have remarkable impact in terms of transmissibility. Both of them, all of them do lead to increased transmissibility, and some of them do significantly affect the vaccine efficacies. So what are we doing in Africa to address that? We have set up a network of laboratories across the continent as part of the Africa's CDC's Pathogen Genomic Institute, working closely with the World Health Organization, the office in Brazzaville, and where we organize ourselves in 3 levels. The first level here in blue are those that we call specialized laboratories. And then the lower level are the regional sequence laboratories, the Institute Pasteur in Morocco, Senegal, the Ninguchi Institute in Ghana, Nigeria CDC, and you can read all the other names there, and the national levels there. Together, our goal is to sequence about 50 genomes across the continent to understand the molecular epidemiology of this virus by the end of the year. So far, through this network, we are organizing ourselves in such a way that we can refer specimens from countries that do not have the capacity to those that do have capacity. And we've moved over 12,000 specimens from 34 member states to the reference labs for sequencing. If you look at the overall data that exists on the continent, together 19,450 sequences have been generated. Of those, 30% of member states have identified the Alpha variant, which is the B117. 27 member states, or 49%, have identified the Beta variant. and 13 countries have identified the Delta variant, which is the variant that was originally reported in India. This graph just shows you another way of looking at the data, where the gray area are the different various variants. But those variants of concern on the right-hand side here that are predominating the continent are the Beta variant that was originally reported in South Africa. Then in orange are the Alpha. And then you see that in green, the little green color there is the Beta variant there. But remarkably, if you look at the way these variants have spread in DRC, it is extremely concerning, and it's taking over very quickly. If you see where the arrow is in March, that is where the variant was first reported in DRC. At that time, the predominant variants were the blue and the orange, that is the Beta and the Alpha variant. But fast forward, you see immediately how the Delta variant has overtaken the pandemic in DRC, completely wipe off the Alpha variant and is pushing back the Beta variant significantly because it transmits over in excess of 40% more than these other variants there. So that is one factor that we believe is driving this pandemic. And we also have anecdotal data from South Africa indicating that this variant is taking over a lot of the space, the infections in Southern Africa. I would not be surprised that in Uganda is the same, but we still have to analyze the data. So because of this situation, we convened a meeting on 8th of May at the highest level, chaired by President Tshisekedi, President Cyril Ramaphosa, and the chair of the African Union Commission, His Excellency Musa Faki Mohammed, where we said it was time to adapt a strategy which was slightly modified from the continental strategy that we had used before. The strategy was underpinned by the need for enhanced prevention, monitoring, and treatment. And it's simplified in 3 pockets here, where we are looking at in the area of prevention, enhanced prevention, where we need to continue our public health measures by rolling out vaccines and ensuring that we avoid mass gatherings, because each time we gather, you offer the virus a chance to spread, to develop risk communication tools, and to deploy community workers, food soldiers that can continue to support the pandemic. We're calling it the 3D approach to support enhanced prevention. Then we have the 5 E's, which is to endorse new tools for guidance for monitoring. If you recall, when we established the continental strategy 1.5 years ago, there were no variants and no vaccines. And we're also encouraging member states to support the need to share data more aggressively to enhance ability to sequence using the Pathogen Genomic Institute platform that we offer, enhance diagnostics, and of course, test people and isolate them, and continue to do sero surveys as those that I just indicated. Those are the 5 E's of the monitoring strategy. And lastly, the 3 E's of the enhanced treatment. Ensure that you have enough supplies for COVID treatment, ensure that member states are better equipped with appropriate oxygen supply, because we see a lot of the deaths are coming in because of lack of oxygen, and appropriate guidance for training, including across the board. Let me now transition to vaccines as I move to my conclusion. As a continent of 1.3 billion people, we've set a target of 60%, which will correspond to 780 million people to be vaccinated. Of that number, 26% or 340 million doses were supposed to come from the COVAX facility, and 400 million from the AVAC. So that will enable us to get up to where we have to be. Unfortunately, this is what we have as of June 21st. 61 million doses of vaccines have been acquired on the continent, of which 49 million have been administered, 34.2 million have received first dose, and 14.7 million have received a second dose. And this represents a coverage of 1.12% across the entire continent of 1.2 billion people, or 1.3. So this graph shows you the coverage. The lighter the green color, the less people have been vaccinated. For example, 47 out of 55 member states have vaccinated less than 1 to 10% of the continent, their population, I beg your pardon. President Tshisekedi, as the chair of the African Union, has launched a partnership for African vaccine manufacturing, which was endorsed recently, just last Thursday, by the Bureau of the Head of State. So we have a platform now to encourage coordination for vaccine manufacturing. And I'm happy that our colleague is here, Thomas, I'm sure you will touch on local manufacturing on the continent, which we are very, very aggressively pursuing. So in summary and in conclusion, the third wave of this pandemic is here. The new wave seems to come with new variants, and adhering to public health measures while expecting vaccines to arrive is very important. There's need to adopt the new adapted strategy, which calls for enhanced prevention, enhanced monitoring, and enhanced treatment. Without vaccines and vaccinations, we'll continue to struggle with this pandemic. Thank you so much for the opportunity to speak with you this morning.
Kengaso, if you can allow me, that was a very wonderful presentation. I'm sure our audience will have some clarification they may need. So please, the audience, put your questions in the chat. And at the end of the presentations, we'll come back to you with clarifications. We'll move on. Next speaker. Our next speaker is Dr. Thomas Quinn, who is the Director General of the International Federation of Pharmaceutical Manufacturers, which is a global association of research-based pharmaceutical companies and associations. It is based in Geneva. The IFPMA has official relations with the United Nations and contributes industry expertise to help the global health community find solutions that improve global health. Dr. Quinn is secretary of the Biopharmaceutical CEO Roundtable, a policy forum of the global CEOs and other member companies. He's also chair of the business at the OECD Health Committee and serves on the board of directors of the City Cancer Challenge, an initiative aiming to improve cancer care in major cities in low and middle income countries. Dr. Quinn has a very detailed CV, and allow me, colleagues, to stop it there. It is available in our abstract book. You can take on and read more details of Dr. Quinn's. Dr. Quinn, we are very happy this morning to have you address the World Health Summit Regional Meeting for Africa happening here in Kampala. Thank you.
Thank you very much, Bruce, and thanks for giving me the honor to address this Regional World Health Summit. Of course, we all would have loved to come to Uganda last year or in person this year. Wasn't yet to happen. But first, I would really, following up on John Nkenga's song, I would really like to congratulate him and his team from the African CDC and also Dr. Moeti for outstanding work done. Looking at the slides deck shared by John Nkenga's song, I think you can really see the expertise, the experience from the African CDC. And in particular, I would also like to congratulate the African Union and the African CDC for the excellent two-day summit around expanding Africa's vaccine manufacturing held in April, where I had the pleasure to be part of. In my talk, I would like to cover three topics. First, I would like to give you an overview on how the innovative biopharmaceutical industry has responded to the pandemic. I would also like to share with you, second, what needs to be done urgently to improve access to vaccines and to improve vaccine equity, which means we are far from being there yet. And I would like to conclude with some reflections on future initiatives for the future, key for the future of public health on the continent. I have to admit, as a veteran of the industry, I'm the first one to admit that more than 20 years ago, our industry did not cover itself in glory when it came to responding to the HIV/AIDS crisis. I'm mentioning that because I've seen quite a few comparisons over the last few weeks or even months to that crisis, but I would like to share with you why I'm deeply convinced that this is not the same and that we are seeing a different action and a different behavior from the industry, but we also are seeing an unprecedented global pandemic. And when you look at how the industry responded, IFPMA, which is the association of the global research-based, leading research-based pharmaceutical companies, including vaccine manufacturers, within a week in 2020 of the pandemic being declared, announced, our industry leaders came up with commitments which were framed on the conviction that this is not business as usual. This is something which needed the industry to respond, not in a competitive, fiercely competing with each other, but in a very collaborative mode, partnerships, opening libraries, sharing, teaming up with others, be it in terms of voluntary partnerships, voluntary licensing, also technology transfer. When I look back over the last 16 months, I can say that the industry did walk the talk, and we wouldn't be where we are now without that commitment. We did join early on 24th of April 2020, ACT A, a partnership. We are parts of the COVAX partnership. We are committed to public-private partnership. Now, what have we done? I think when you look at the vaccines, of course, we moved sort of from big concern last fall, and it was mentioned again now about vaccine hesitancy, to, I think, enthusiasm and excitement about the fast and speedy development of vaccines. When you look, and it's most of time forgotten, when you look at the target product profiles, the objectives of the FDA, of WHO, of the EMA, the objective more than a year ago was hopefully we would see vaccines with an efficacy of more than 50%. And that was challenging. We knew it wouldn't be easy. We knew there would be vaccine projects failing. But when you look at the mRNA vaccines, the first ones to be approved by stringent regulatory agencies, the big surprise was they exceeded 90% efficacy. And I think the really positive news, although John Nkengasong in his slides, he showed that there is reduced efficacy, including of the mRNA vaccines, in particular after the first jab, to some of the variants, but they are still pretty much as effective as those more than 90% indicated before. When you also look at where does our hope reside, which vaccines for time being are used by COVAX or have been procured by the African Union or countries bilaterally, it shows basically that innovative vaccine manufacturers have delivered, have come to the forefront. Now in COVAX, for a number of reasons so far, most of the vaccines distributed were Oxford AstraZeneca vaccines, but basically when you look at the procurement deals COVAX has signed, all of these vaccine manufacturers are innovative vaccine manufacturers: AstraZeneca, Oxford, Pfizer, BioNTech, Moderna, and J&J. The industry has succeeded bringing vaccines to people at record speed. I'm sure that in Africa, you do know that the fastest vaccine developed ever historically was the one against Ebola, and it took 4 years, and those 4 years were seen as an amazing feat. Now in COVID-19, it actually took 326 days. 326 days without cutting corners, 326 days with stringent regulatory control and approval. And therefore, I think quite often when we are now feeling agitated about why can't we have a vaccine immediately? Why isn't it possible when you have these vaccines approved to push, the presidents push a red button on a red carpet, and then the billions of doses are rolling out? I think one of the reasons is that many people underestimate the complexity of vaccine manufacturing. When we started doing this, we actually said upfront, we will see disappointments, we will see failures, and we have seen some of the biggest vaccine manufacturers in the world not yet there with the vaccine. We have seen other of the really top 4 vaccine manufacturers who had 2 projects and they had to abandon because it didn't work, or they had to give up because there was a contraindication with some other diagnosis. When we look at John and Kengasong shared the numbers, just barely more than 1% of people in Africa vaccinated right now. But when we compare that, for example, to the H1N1 situation, where it literally took a year for those first vaccines to reach people, in this case, it was 88 days after the first approval. And the first doses did reach Accra and Abidjan on the very same day the first doses reached Tokyo. And when you look at the numbers of vaccination, for example, in Japan, they aren't that much higher than in Africa. Therefore, I think we do see the challenges, and we did know that increasing capacity would be very complex. We look at, and it's rarely talked about, global vaccine capacity in manufacturing pre-COVID-19 was basically 3.5 billion if you don't include seasonal flu vaccine, about 5 billion doses if you do include seasonal flu vaccines. We knew from the beginning we would need to vaccinate the world. We most likely, with one exception, the J&J vaccine, we would need 2 doses. Therefore, if you look at the adult population, you need about 11 billion doses to vaccinate 70% of the adult global population. That means literally trebling, excluding seasonal flu, global vaccine capacity. We knew this would be a daunting, colossal challenge, and we knew this would not be possible without partnerships such as between Oxford, AstraZeneca, with multiple partners around the world, including Serum Institute of India, Fiocruz, and Aspen. Pfizer teaming up with BioNTech, Johnson & Johnson, as was recently announced in the Quad meeting, teaming up with Biological E and many other partners like Aspen. Also Mrna teaming up with many contract manufacturers. Without these partnerships, it would not be conceivable to reach the target. Scaling up from 0 to hopefully 11 billion doses this year. We have now close to exceeding 3 billion doses manufactured. And we do know that there are many problems because vaccines need hundreds of components. For example, the Pfizer-BioNTech is made up of 286 ingredients coming from 86 suppliers going through 19 different countries. And we do know that actually technology transfer, and I will say a word about that later, is a very complex, challenging problem. And we also know that one of the scarcities is the lack of skilled workers. For example, the Mrna vaccine for outside North America is manufactured, the active substance, by one of the most experienced contract manufacturers in the world for biological production. they struggled for a long time and was seriously behind schedule to scale up. And the big bottleneck there was skilled labor. They were slow in recruiting. We have seen very seasoned contract manufacturers like Emergent Biosolution actually leading to wasting 60 million doses of a vaccine because something went wrong. And we see, for example, that even on the relatively simple, emphasis on relatively simple fill and finish, the contract between J&J and Aspen was signed in November last year. Based on best of my knowledge, I think the first doses hopefully will be rolled out at the end of this month. We did realize early on that there could be bottlenecks, that we were confronted with challenges such as trade barriers. And that's why we did reach out from IFPMA already in February to CEPI, the Coalition on Epidemic Preparedness Innovations. And Richard Hatchett and we co-created the Chatham House Summit, which was followed by the WTO Summit organized by Dr. Ngozi and some of the regional summits. We realized there where the scarcities are, the single, giant use bioreactors, the giant plastic bags, lipids, filters, and many other components. And we did co-create with COVAX, with CEPI, with Gavi, UNICEF, and WHO, the COVAX Manufacturing Task Force. In this context, I think it's important to say that companies have pursued a number of avenues, some of them highly focused, highly concentrated, and one of the most successful is clearly the Pfizer-BioNTech, on track to have increased their original estimated capacity from 1.3 billion doses for this year to 3 billion doses for this year. Their bottleneck is raw materials, as they told me. And the challenges which we see continue to be trade barriers such as Defense Production Act, trade barriers such as when you look at COVAX, actually the idea was that 50% of Serum Institute capacity estimated at almost 2 billion would be sent to Africa in real time, which means 50% kept for domestic use, 50% sent abroad, because of the terrible spike of COVID-19 in India. Nothing is coming out. You can argue that is actually a breach of contract, but you also, of course, you see the problems India was facing, and therefore one really has to address this fast and critically. And therefore, innovation is underway. We are making progress, but we are far from being there yet. And in particular, as John Nkengasong has said, vaccines are not reaching even vulnerable populations equitably. That's why I personally find it really shocking that we do see vaccination in some countries, rich countries, of 12 to 16-year-old kids at a time when vulnerable people in Africa haven't received even the first doses yet. And that's why I'm firmly convinced that vaccine delivery to Africa must be speeded up. We in May joined up forces with our colleagues from Bio, from Pharma, from the European vaccine manufacturers, and we announced we need a 5-step plan to address this situation. The first one is, given the situation in India, the only fast way to improve equitable access is dose sharing. We did call out to world leaders, you need to start dose sharing. It's unacceptable that initially countries did hedge their bets because they didn't know which vaccine would work, but then they moved to hoarding. And you do have countries with 6 to 8 doses per person in their country, and they haven't really been sharing on a big scale yet. Very pleased to see the response at the G7 meeting in the UK, the announcements from the US president, from the European Union, President Macron, and I do hope that we will really see dose sharing now happening quickly, not in Q4, but actually in Q3. And we welcome the commitment. You also saw the commitment from big global vaccine manufacturers, in addition to AstraZeneca, Oxford, Pfizer, BioNTech, Moderna, and J&J committing to delivering 3 billion doses for low and middle income countries, Pfizer, 1 billion this year. We need to continue optimizing manufacturing, optimizing production. That's why, as I mentioned, we are part of the COVAX manufacturing task force, and I'm very pleased to see the collaborative spirit in there. Third, and that's where Dr. Ngozi, the leader of WTO, I think has played a critical role, we need to call out trade barriers. Many people were talking about the challenges of the Defense Production Act in the US, and we have seen at one time that there could be similar barriers in other countries. This has hampered efficient vaccine scaling up. Fourth, and it was on John and Kengasong's slide, we should not underestimate the challenges of country readiness. One of the reasons why I think COVAX was a little bit slow in procuring mRNA vaccine was not just concerns or interest to buy cheaper vaccines, it was also logistical concerns about the need for ultra cold chains, the need for infrastructure investment. And sadly, by the time everybody realized, oh my God, we do need mRNA vaccine, a lot of the doses had already been procured by others. Country readiness remains an issue. I will not go into naming countries, but I have seen that doses were not used in some African countries, whether it's because of infrastructure challenges. We have heard that whereas budget were there for procurement, the budget for the absorption, for the administration hadn't been provided for. We have seen, I think, some elements of vaccine hesitancy. We actually see it in industrialized countries too. And last, we do need to continue to drive further innovation. Literally every vaccine manufacturer is already working and fairly advanced in booster vaccines, in improved formulations. For example, one of them will use the half dose because it's considered that sufficient. You will have improved logistical so that the cold chain requirements will not be quite the same. Therefore, everybody is continuing to drive further innovation. I also expect we will see vaccine manufacturers who were delayed, not there yet, come in with in 22, so that I think the current problem in terms of shortages of vaccines should be resolved at the latest in Q1 2022. Let me finish by making some specific comments on Africa. We will support all efforts by our companies, governments, and stakeholders to ensure greater supply of doses to Africa, to support COVAX, and to work with the African CDC and the African Union for improved, fair, and equitable access. We will work collectively to address vaccine hesitancy. I saw a question on that. We have, for example, launched a social media, digital media campaign at Team Vaccine, which has been downloaded and the videos watched by more than 60 million people, which is quite extraordinary. And we are fully open to look at possible future local production of vaccines. But I want to be very honest and transparent. This is not a solution for the short term, for the next 3 to 4 to 6 months. As John and Kengasong in his vision at the African Manufacturing Summit said, the objective would be to reach 60% self-sustainability by 2040. This will need time. I do believe that we can see pretty speedy movement, but it's more for the next 3 to 5 years than for the next 6 to 12 months. And as an example, you saw the announcement, for example, of BioNTech about the investment in Singapore, and realistically, they expect That may be operational if all goes well by 2023. Therefore, we need to be realistic about the needs to train skilled workers, the need to get good manufacturing processes, quality assurance, everything in scale. But we do see a lot of interest from governments such as Germany. I'm at the roundtable organized by the German Ministry of Development this coming Thursday. We heard President Macron. We see the UK, which helped to organize the manufacturing summit in April. And I do believe one really needs to be careful to make sure that if we do have, and if you do have local manufacturing capacity, you have a sustainable ecosystem. We from IFPMA also looking to working together how we can contribute to the Partnership for African Vaccine Manufacturing proposed following the summit, and working with John Nkengasong and his team. In particular, and I really want to close with that, it will be important to create the African Medicines Agency, AMA, and we are ready to share knowledge and best practices. We were involved in the creation of the European Medicines Agency, and you really need to look into reliance, GMP, post-approval changes, samples, and biotherapeutics. We will do this as IFPMA, supported by companies, and as member of the cross-stakeholder alliance, the African Medicines Agency Treaty Alliance, AMATA, launched last week at the joint meeting on the future vision and strategy of AMA. Thanks for inviting me, and I wish you a very successful World Health Summit in Kampala.
Thank you very much for the presentation. And I want to encourage the audience to post the questions in the Q&A section. We'll be getting to them. I hope I can be heard. So, so far we have questions in the chat. Yes. Okay, I'm going to read them from there. So we have a couple of questions in the chat. But before I go to these questions, I want to thank our speakers this morning for giving us such insightful presentations. Our first speaker was Dr. John. And from that presentation, I wanted to seek one clarification from Dr. John. From the table that you showed us about the seroprevalence, one thing which stands out is that there doesn't look to be significant difference between males and females in seroprevalence. However, when you go to the clinics and to the hospitals for people who are seeking care, at least from where I practice from, we see many, the patients are dominated by males. Is there anything to explain this kind of difference from what is seen when you do population-based serosurveys? Probably, Dr. John, you could be addressing yourself to that question as we get more from the Q&A.
Can you hear me? Can you hear me?
Okay, we've heard you, yes.
Okay. No, I mean, thank you. I think if you look at the breakdown of the infections, you have for Sierra Leone, it was like 3.2% for females and 2.2% for males, 1 percentage point there. Uganda was like just the same, 20.5% and 20.7%, slightly higher. Then in Zambia, you see the reverse. It was a little bit higher in males, 15%, versus 10% in Zambia. Sorry, in females. And then in Zimbabwe, you also had the reverse where females were slightly higher, serologically higher infections than in males. So you really don't have, I don't think there's a consistent pattern that shows that it's either females or males there. I think it all depends on the population. I mean, some population like in Uganda, you can see that it was just like a tie, 20%, 20%. So it's I would not draw any conclusions on that data now with respect to gender. Behavior counts and individual behaviors in each country also matter. How what women do and who goes out more, it all has to do with exposure. Who is the breadwinner, who goes out more and is more exposed, and who hangs out in crowded populations and who attends political rallies and things like that. And I think that those are all factors that we have not played into the analysis. But the key message of this slide is that the reported cases backed by PCR data is far less than the serologic data, the number of people that have been exposed serologically.
Thank you very much. So for Dr. Quinn, I also have one as we prepare the ones from the chat. Actually, this also could go to John. From the data that you've shown us, it looks like it is going to really take a significant amount of effort to make vaccines available for everyone. And probably, I wanted to see what our panelists think about strategies that mix vaccinations and other interventions to control the pandemic. The vaccines are very important, but when you hear, looks like it is going to be a lot of effort. Are there any models that we can look at to see how vaccines sit in the midst of other interventions to control the epidemic until such a time when the vaccines become available? I heard from Dr. Quinn the 236 ingredients to make one vaccine, 86 suppliers. So this also goes to John. How are we going to walk through this and make sure that vaccines can be manufactured on the African continent? Thank you. I think maybe Thomas, you could go first and then John next.
I think the honest answer, and John and Kengasong, I'm sure he knows what I mean, is that at the beginning of the pandemic, non-pharmaceutical interventions were by far the most effective. And my feeling is they were more effective in some parts of Asia and Africa, because Africa is used to epidemics, than in many parts of Europe and the US, where, you know, kissing, hugging, shaking hands is very common. And therefore people needed to get used that social distancing means social distancing. The second element in terms of outside vaccine, I think by now, most people and experts I talk to admit that we will never reach herd immunity. The virus is going to stay with us. Therefore, we, in addition to vaccines, we will need treatments. And whereas we had a big success on the vaccine side, I think on the treatment side, there was no fast magic bullet. We did have some success in terms of reducing mortality with dexamethasone. We did have some success, but relatively complex to administer with antibody cocktails, with some repurposed medicines like remdesivir, but we don't have a magic bullet yet. There is hope that the antivirals, the new ones, which will come up, first results expected end of October, may be of a help, but this remains challenging. John?
I think that, so first of all, I think, let me address both questions. And now Thomas will agree with me here. We have the tools in our hands with respect to availability of vaccines globally to blunt off this virus. We absolutely do have the tools. We have excess vaccines all over in countries that have secure more vaccines than they need, and they are making aggressive move to vaccinate their populations. So the behavior component that Thomas touched on is very important. Behavior has been a critical component in the manner in which we have reacted to this towards this pandemic. Either it's political behavior not appropriately conducted, or behavior at the policy level where people decide to accumulate these vaccines and not releasing it. We are not going to win the war against COVID-19 in Africa by vaccinating at the pace at which we are vaccinating. And if we do not win it in Africa, the world will not win because of these variants. It's very, very unpredictable what the variants will do, especially with respect to people that have been vaccinated and susceptible to infection. Again, we have seen this in Israel, we've seen this in Seychelles and other places there. So we do have the vaccines. The second thing I want to say is that we have to move from pledges to action. I mean, it is very good to go to the G7 meetings and pledge and make pledges. Pledges are not, pledges are good. We welcome that as a continent, but they are not vaccines. They are pledges. So, I mean, action needs to be taken. I really actually say that in as much as we are very grateful for these pledges, we say that you don't need a G7 meeting to make an announcement. People are dying. I mean, if you have the vaccine, release them now. Don't wait for an opportunity for media and op-ed to make those announcements. That is the kind of behavior that is surprising to me. Why that we know what to do. We have the tools, but we are waiting for maybe an event in September during the General Assembly meeting to make an announcement, and people are dying and whatever. That is not what we should be doing now. I think we have the tools in our hands. Second, with respect to vaccine manufacturing, our position, and Patrick knows about this. We organized a meeting that Patrick was there, Thomas was there, beg your pardon, in April 12 and 13. And in 2 days, 40,000 people came on that platform, Thomas. It was a clear indication, not just in Africa, but the whole world, that they recognize what the continent of 1.2 billion people were going through and needed to do. As a continent of 1.2 billion people, we import 99% of our vaccines and manufacture 1% and consume 25% of the world's vaccines. You cannot continue to guarantee their health security by that. So what we are saying is that we should start now. A journey of 1,000 kilometers starts with one step. Yeah, and understand that the short-term needs are our global solidarity and cooperation to redistribute those vaccines, get ourselves prepared so that we can immunize. In as much as there are countries that will struggle in their vaccination, we can rally around those countries, and there are not many. When vaccines arrived in Ghana, they were all gone. Vaccines arrived Togo, gone. They arrived in Rwanda within 1 week, gone. So it's Nigeria. So there are so many countries in Africa, and we have not even, we at Africa CDC and the African Union have not gone into full gear in terms of campaign for vaccines. Why would you go up there and be campaigning for vaccines if someone in Uganda says, okay, now you're telling me to go get vaccines, show me where to go get the vaccines, and I turn around and say, well, I don't know where you get the vaccine, but go get your vaccines anyway. Vaccines are very important. And we have seen this in Cote d'Ivoire, where they started off with some kind of hesitancy. The country went into full gear campaign, and the vaccination went right up the roof there. So if vaccines are available in a predictable manner, countries in Africa will step up. We will step up as Africa CDC, to working with WHO Afro to make sure that people get their vaccines. So I think just in conclusion, we have to bridge that gap between where the vaccines are and where the needs are, and make sure that we vaccinate together. And I'll just end by saying that what bothers me so much is, again, along the lines of behavior, is Europe imposing restriction on countries in Africa, where I think there's a list of 13 or 14 countries, and only Rwanda is included in the list of countries that, for African countries that can travel to Europe. Now we are seeing another restriction that if you have received the AstraZeneca vaccine from India, you cannot travel to Europe there. Well, COVAX endorsed that vaccine. COVAX distributed the vaccine. The vaccine is purchased by European and North American taxpayers' money. And now to say that that vaccine that most people have used in Africa, you cannot travel to Europe, that vaccine is not even considered, is to me, I'm speechless, just to put it very bluntly. I mean, I'm not a diplomat, but there's no science behind that. Absolutely no science. There is no data to show that anyone that has received the vaccine has less inferior immune response than other vaccines. And if COVAX, the people sponsoring COVAX knew that that was a suboptimal vaccine, why did you pay for that vaccine? And why did you ship that vaccine to Africa? I think those are the kind of behaviors that are really getting us completely frustrated on the continent with respect to our ability to cooperate and show global solidarity.
Thank you very much for responding to those questions. Very grateful. Can you show the chat? So we have now comments and questions from the Q&A. I will read some of them. The audience is very active, so I'm going to choose. But anyway, we give chance to the first person to ask a question. And I think, John, you touched that a little bit. Anonymous attendee says, as vaccines are the key to end this pandemic, what are your thoughts on how to tackle the issue of vaccine hesitancy? I think, John, you will handle that one. Let me read
absolutely.
3. Yes. Let me read 3, then we can answer. Then the second one, as a medical student in Africa, what potential do we have to participate in the promotion of the strategies for COVID-19 management? I think that speaks to the ease that John introduced to us. Then the third question, I think this will be handled by Tom. There is news of the EU not recognizing COVAX. What are your thoughts on this? So let's handle those 3, then I will sample a few more from the chat. Thank you.
So let me perhaps start with the issue of vaccine hesitancy and state some facts. Yes, vaccine hesitancy is there. We conducted our own studies at Africa CDC way before vaccines were available. And we showed that, and this was based on a large sample size of about 15,000 people in 15 countries, that it ranged from about 60% of people that were willing to receive a vaccine if one was available to about 95%. So that is the fact that it does exist. The second thing is the fear factor, that until people start seeing people receiving vaccines, they will continue to have fears and misinformation and disinformation. We cannot ignore that. The third and very important one that I would like anyone to listen is that vaccine hesitancy in Africa is not static, that we see it at some point and then it disappears. And then when news breaks like what we are dealing with now, the COVID vaccine the AstraZeneca vaccines from India that the European EU is saying they cannot travel to the EU. That will create a lot of further vaccine hesitancy because it will impact people's behavior. The question that will come to people's mind is exactly, so if so, why did they send us these vaccines? If that was, I mean, that is extremely devastating for programs that we are running in Africa. So, and it will impact vaccine hesitancy. So we should be very careful with how we deal with, we should be honest with what we say, we use data to inform decisions and policies and not just come out with and not react to things that will continue to further make it extremely difficult for people to accept vaccines on the continent. Over to you.
Yes.
I think maybe you asked me to come in with something in terms. It also a little bit addresses the issue of the vaccine hesitancy. In my view, something which is absolutely vital and crucially important is for trust creation. We need to share data, as John did. We need to talk about what do we know about variants, about efficacy, about problems. And we, for example, came out fairly early last year and said the regulatory agencies need to scrupulously do their stringent regulatory work. And I think we have seen that happen. We have seen questions raised, we have seen delays in approval, we have seen debates, and I think that will help to increase trust. In terms of the travel restrictions, I fully understand, John. I have to admit, we have some similar restrictions still going on in Europe. My son, for example, is in Oxford. He could only come to visit his parents going 2 weeks into quarantine, which means even within Europe, not least because of the Delta variant, we still have some pretty severe travel restrictions happening. I've still, till end of August, we are basically working on home office, no longer mandatory, but we are still extremely cautious. But we really need to make sure that we involve, I'm sure that John read Stuck by Heidi Larson. We need to involve the communities when it comes to creating vaccine confidence. And we need to really communicate on what we know and what we don't know yet in terms of the vaccine efficacy or relative efficacy.
Questions. I want to ask people who have posted comments and questions. Secretariat will compile them and probably provide responses on the website. But for now, join me in thanking our presenters this morning who have helped us understand the issue of COVID-19 in Africa. As expected, we shifted very quickly to discuss vaccines, but I think that's the most topical issue at this point in time. Thank you very much, Dr. John Kengasong and Dr. Thomas Quinn, for participating in this discussion. For our audience, thank you very much. Please log on to other sessions which are ongoing.